Good afternoon, and welcome to today's panel on preparing for unmedicated birth, hosted by Tallahassee Memorial Healthcare. We thank you all for joining this year's Baby and Family Fair virtual series and look forward to answering your questions and giving some advice about preparing for an unmedicated birth. I'm Amy Kimmel, and I will be your moderator today. I'm a birth doula and childbirth educator. I've been doing that for almost 10 years. I'm also a mom of three, my last of which I had this past July at TMH. And I'm really happy to be joined today by some great panelists. So please welcome me in joining certified nurse midwife, Miriam Gurniak. Miriam has spent her entire midwifery career in North Florida. She cares for women before, during, and after pregnancy at the TMH Family Medicine Residency Program, Anderson Brickler Midwifery. You can also find her up in TMH's labor and delivery unit, and she'll be delivering babies and caring for moms in triage. We are also joined by Joanna Fato, and she's the assistant nurse manager over TMH's high-risk labor and delivery operating rooms and post-anesthesia care unit. Joanna has years of experience caring for both high and low risk moms during their deliveries and enjoys supporting mothers through natural childbirth. Thank you so much for joining us today.
Happy to be here.
So many of you submitted questions ahead of time, and we will be diving into those momentarily. If, as we go, you come up with some extra questions, go ahead and use the Q&A feature here in Zoom to submit them. They'll be looking through those and sharing them with us as we go. And if we haven't covered it, we will catch them all at the end, make sure we get those questions. So without further ado, let's get started. So Joanna, let's start with definitions. We hear the term natural birth a lot. What exactly does that mean?
Yes, first, let me thank all of you guys for having me on today. I'm excited to talk about this topic. So I think defining natural birth is something that can be kind of confusing for people. So I think this is a great question. There are those folks that say a natural birth, they want to have a natural birth, and what they're saying is they would just want to have a vaginal birth, no matter what that means. Other people say we want to have a natural birth, and they mean unmedicated or low intervention type of a birth. So I think it's important when you come into the healthcare, wherever you're going to have your baby, to describe what you're really wanting. Don't just say, I want a natural birth, because that can mean a lot of different things. Really be open with your healthcare team and let them know what that really means to you.
Absolutely. So what does it mean to have a low intervention birth?
Yes. So low intervention births, that can kind of be different depending on your risk level and kind of, what is going on with you in your healthcare. If you are a low risk mom, that could be intermittent monitoring, being able to change your positions, be up and moving, letting your water break on its own, not adding any medications to your labor. And so it's that kind of a thing, low interventions where we're not really intervening and we're letting your body do what it is naturally supposed to do to get you that healthy baby.
And then what about the unmedicated birth? When you hear that, what kinds of things do you think those families want?
Right. So it can kind of mean two different things. So on one end, it could be pain control unmedicated. And then as far as it can be unmedicated, as far as induction means. So as far as the induction goes, if you want to be unmedicated, that would be we're not intervening at all in your labor and let your body just do what it naturally does and give you those contractions that your body would naturally do when you're in labor. Mm-hmm. Unmedicated as far as pain control wise, then that would be us not intervening with pain medication. We have different options. Some people choose IV pain medication as opposed to an epidural. If you were going the unmedicated route, then you would, not want any IV medications. Mm-hmm. And then there's also the epidural. The epidural is not systemic, so that medication would not go to your baby. It just kind of coats those nerves to help you manage those contractions. And if you were wanting to be unmedicated in that way, then we would not do an epidural.
All right. So Miriam, let's say I'm interested in having an unmedicated birth. And I am. Where do I begin preparing? Where would I start?
Well, I think there are a lot of different options. And I think it starts in thinking about what does pregnancy and birth and labor and delivery mean to you? Because for some folks, they want to have a very specific birth plan of what their intentions are, what the roles of the different healthcare providers are, the staff, all of that. And often the thing about labor and delivery, if we're talking specifically about labor and delivery, is that, a lot of flexibility is important. So I think it's really important to talk with your provider. I'm making the assumption that the people we are talking to are already pregnant and already have a healthcare provider, and that may in fact not be the case. So let me take a step back and say that at TMH, we have we have 3 sets of providers who deliver babies. We have OBGYNs, we have family docs, and we have certified nurse midwives. Mm-hmm. And all those folks also provide prenatal care. So the decision about where you're going to get your prenatal care, what kind of group you want to be in, what approach you want to take really starts before you come in the door in labor or just trying to decide whether or not you're in labor. There are a variety of approaches, and I think that's a fabulous and wonderful thing. One of my takes on all of this is that there are as many different providers and methods and approaches as there are personalities of the rest of us. Thank goodness. Mm-hmm. We are so lucky at TMH that you can keep moving and spend some time in the labor tub if you want to. And just last week, I had someone who said to me, I'd really feel more comfortable if I were pushing this baby out on my hands and knees, and that's what she did. We also have folks who are in situations where they want to have an epidural and be supported in whatever situation works best for them and their family. And I know COVID's changed a few of those things. So I'm just really happy and proud that at TMH, we have lots of different options and the flexibility to be able to meet lots of different people's needs. I think it is important to talk through what your expectations and hopes and dreams are with your OB provider, whoever that provider is, and that you come out of the delivery not only with the baby in your arms, but also feeling that you were listened to, your needs were met, your questions were answered, you were able to lead and facilitate the process that worked best for you, and that you feel that you were an important team member, able to advocate and get the support that you needed.
Mm-hmm. So I hear 2 things in what you're saying, Miriam. Part of it is finding a provider that matches up with what you're envisioning, and kind of explaining to them what you're hoping for prenatally so you can make sure you're all on the same wavelength. And then the other part of that is that there are a lot of options to explore. So in the options that exist, I know that there's a lot of classes, there's a lot of books out there. Where do you recommend that parents start when trying to navigate that and figure out where to go? I know
I actually Googled childbirth education Tallahassee today because, I have an 18-year-old and a 23-year-old, and things have changed of late. Some of the options that were available when I was a pregnant mama are no longer available, and other new and great things are available. And we've also had to make some big, swift shifts because of COVID recently. So I think it's important. One of the things I talk to people about when they're asking me about recommendations for pediatric providers is I ask people to talk with their friends and talk with folks who they think their parenting style is going to be similar to theirs. And in the same way, I think your obstetric or your pregnancy style, what's important to you needs to be teased out in a variety of different contexts, because different people have very different needs and interests. And so, I also think flexibility is the key. One thing I always say to folks, this is not about where to get more information, but I think going into childbirth with a really rigid mind can be really difficult for folks. I've had patients who came in 9.5 centimeters dilated, determined that they were going to get an epidural, and held that baby in, spending more time waiting for an epidural than they could have had the baby in their arms because of their thinking being so rigid. I've also had patients who spent months practicing specific breathing patterns, specific techniques, whether it was Lamaze, whether it was husband attended childbirth, whether it was hypnobirthing, whatever it was, that when things shifted in labor and they had to go from he who breathing to who he breathing or whatever, that was a real stumbling block. So I think you could be, unfortunately caught by rigid thinking in all directions. And I think that's the same issue when you're looking for providers, childbirth education, doulas, whatever you need in your path. It's your path, just like it's your body to design and put together what works for you, and not be afraid to make changes. We often have people who will transfer into our practice partway through the practice or end up somewhere else because the communication is critical. The ability to feel like you are getting your needs met, being listened to, able to advocate for yourself, and have your partner and your support team advocate for you. All those things are absolutely critical, and there are different folks out there for you. So we want to make sure that you don't feel locked into something that makes you uncomfortable.
Absolutely. What you mentioned about picking providers just reminded me of how many times friends and family have said, Amy, you work in birth. Who should I see? Who's a good care provider? And there's no one size fits all answer to that, because it really does depend on what kind of birthing experience do you want? What's your personality like? And how does that fit with each person? Because I've seen in the birth room so many different combinations of people that wouldn't be the provider for, Susie, but it is for Sally. So that it works out really well when you're flexible and when you seek out care that fits. So let's see, you've kind of covered some of these questions before I asked them. Joanna, a lot of people associate natural births with home births. And I know Miriam mentioned caring for transfers, but is it possible to have a natural birth from the start in a hospital?
Absolutely. Absolutely. The good thing about having coming in and wanting a natural birth, but being in that hospital setting is that, like Miriam kind of said, labor is unpredictable. We cannot foresee how it will go. There are obstetrical emergencies and complications that can happen. And being in that hospital setting gives you that security net underneath you, that if you do run into complications or have an emergency, or your baby has an emergency, that you have a full team there to be able to take care of you. I can speak to Tallahassee Memorial Healthcare and our labor and delivery. We are the region's only high risk OB, and we're also have the region's only level 3 NICU. So having those resources available for you if that's needed, I think is a really important thing to have that kind of there to catch you in case you fall. But our nursing staff is all trained in caring for mothers when they're laboring and doing things naturally. We encourage our patients to get up and move, use our whirlpool tubs to get in and kind of labor in. That feels really good, especially during that transition period when that can be the most intense. We have birthing balls and peanut balls, squat bars. We have all the resources that you would need, but you also have that safety net just in case there is a complication or something does go a little bit awry or, away from the plan that you would have ideally had. You have that medical team there in your back pocket that can step in and help you to the outcome to be a happy, healthy mom and baby.
And I think also it's important to say that you have a broad approach and deep support of who the different providers are at the hospital in that circumstance. Because, there are always going to be moms who are going to have planned deliveries out of the hospital. And fortunately, there are safe options to do that. But there are also always of that set of folks going to be folks who need to come in. And I think TMH does an excellent job of acknowledging and working with the disappointment that can be part of that, but also the hope and the ability to continue to support those families in finding things that we are still able to do to encourage them along the path they were hoping to take. In the sense that that we are welcoming, we understand that a transition has had to happen, and we are here to normalize as many things as we can normalize, and are very much, I think, able to do that while giving you the absolute best safe medical support that's needed, obstetrical support that's needed.
I know in some of my experiences working as a doula, I've had home birth patients who've transferred, and the experience, like you said, is somewhat disappointing. There's some worry that the desires you had at home wouldn't be listened to. And to brag on Nurse Fry for a moment, one patient in particular who transferred did not have a written out plan because she had discussed everything prenatally with her midwife at home. And so Fry sat and wrote on the back of a piece of a form all the things that were important to that mom, to make sure that those things still were stuck to as much as was possible given the medical changes. And that was just so crucial, and such an act of compassion from the nursing care aspect of just realizing that, like, hey, we're here because you medically need us, but we want to help you emotionally and mentally well as well. So I love
that's
that.
Been my experience too.
TMH does that.
I think people are almost without exception genuinely delighted and surprised with the care that they get in a transfer. They'll say, I had no idea it could be this great, or I'm so delighted to find out it could be this great, or I really appreciate the fact that, you know, you were able to do this, this, and this for you. And I do think we do honor and want to support family-centered care.
Mm-hmm. And then one of the things Joanna mentioned, you were listing off the various items that you can ask for comfort. So the tub with whirlpool jets. And I know sometimes that it can be, I've seen it be very tricky to stay on the monitor in that. But I've also seen the nursing staff go above and beyond to hold a monitor on, or to come in with a Doppler and listen, because the value of that comfort and that relief for moms who are trying to give birth unmedicated, that really helps. And then you left off my one favorite comfort item from my own birth was the Cub inflatable.
Oh yeah, those are fantastic.
Yeah, so those are kind of a newer item, and not a lot of people know they exist. But I've seen them with my doula clients. I've used one myself, and I love it. So the Cub is a inflatable birth stool. It functions a little bit like a birth ball when you're sitting on it. But then also you can lean over on it, and the shape of it, it's a little U shape. So that center cutout allows for your belly to be, have some space, and also to be kind of nested in a comfortable way, compared to when you lean up against a birth ball where it smushes your belly. And so I found that to be invaluable. I absolutely loved it. So that's one other thing that folks can ask for.
Absolutely.
As well. Can I go back to also the issue about a birth plan? Yeah. People ask me whether or not they should do a birth plan. And what I always say to them is, yes, I think you should do a birth plan, and let's go over it together in the office. Mm-hmm. Because my experience is from the standpoint of our practice, the midwifery part of the family practice program in Anderson Brickler, is that 90+% of what people put on birth plans is what we do anyway. Mm-hmm. And I think that's just enormously reassuring for folks. Yep. We go up and down the list. And, if there's something that we talk with that isn't one of those automatic yeses, then we can talk it through so folks aren't caught by surprise. But I really think it reassures people that we are almost always all on the same page.
Mm-hmm. What are some of the things that you commonly see on a plan that you're like, yep, we already do that?
Skin to skin, delayed cord clamping, intermittent monitoring, keeping moving. One of the things I tell people all the time is when you're laboring and you feel like you hit a wall, change positions. It's really important to keep moving. Really, really important to keep moving. Put your arms around your partner's neck and slow dance in the room. You know, use the birth ball, go hands and knees, do all those different things. We have rocking chairs in every room. We want you moving around. That's physiologically important. I just blanked on what I was going to say. Oh, I know. I also wanted to make sure that people know, I know there's been some real confusion about the midwifery service with family practice. Dearly beloved and wonderful, I happened to see him yesterday, Dr. A.D. Brickler did in fact retire. However, we still have Anderson Brickler Midwifery staffed with 8 midwives. We are part of the family practice residency program. We are available 24/7 for labor and delivery because we always have a midwife in triage, and we are the primary OB staff person for our program at nights and on the weekends. And I think people are confused because they know Dr. Brickler retired, but the rest of us are honored and delighted and determined to continue the legacy of, as he said, you know, he feels strongly that promoting midwifery care was probably the most important thing he did.
Yeah, carry on his legacy is wonderful. So we've answered a couple questions, so I'm trying to find one we haven't gotten to. I'm going to ask Joanna, can patients labor at home? When is a good time for them to think about coming to the hospital? How does that work?
Yeah, sure. So they can definitely labor at home. I do recommend that they have that conversation with their provider so that everybody's on the same page, that the provider knows that that's kind of the mom's plan and can give her some education on when to come in. What we typically say to patients when your contractions are, you know, every 2 to 5 minutes, they're getting increasingly stronger. The frequency is starting to get closer. If you have any vaginal bleeding, if your water breaks, those are all things that you may want to go ahead and come in and let us get you checked out to make sure everything is healthy and normal with the baby. And then you really want to monitor that fetal movement and make sure your baby's moving good. And then, you know, whenever things kind of get going really strong, then come on to the hospital. If you come into our triage area, that's where you would come. It's staffed with 2 nurses that are specially trained in that area. And then we have a provider there 24/7. They'll lay hands on you, make sure that everything looks good with the baby. And then if you're deemed to be in labor, then we'll, you know, keep you to deliver in one of our labor suites. But if you're not, then they may say, okay, you can go back home, come back and we'll check you again. And some patients kind of do that. They kind of go back and forth. We've had patients that come in and they're not as dilated as they thought they would have been. And they talk with the provider and the provider gives them the option to go home. So it's really having that open communication with your provider, and then kind of a plan can be made between the patient, the nurses, the provider on what kind of, how we want to, you know, move forward. And then that's kind of how we progress things.
So Joanna, one thing I've heard in the back and forth of triage is a lot of people are afraid that they're going to be annoying, or they're embarrassed about a false alarm that they think they're in labor and they're not. What would you have to say to moms in that situation?
Yeah, so that's what we're there for. We're open 24/7, and we're open for people to come in. If you have a concern about your pregnancy, I would rather you come in, let me put my hands on you, let you see that everything is okay, and then you can go back home. No big deal. I would rather you come in and know everything is fine than be sitting at home worried that something's not right, or, you know, us miss something. So no, that's exactly what triage is for. Please, please, please feel free to come and see us.
Absolutely.
I agree with that. And it's the midwives who are staffing triage as well as the nurses. You know, part of our job is education, whether it's education in the office or whether it's education in triage. I also want to help people think about how to handle labor contractions when we talk about coming in, whether they're 3 minutes apart or 2 minutes apart or 5 minutes apart or whatever. I tell people if it's a first baby, contractions that are 3 minutes apart that you can't walk or talk through for at least an hour. Because yes, there are starts and stops. It's warm-up exercises. Those contractions are real. It's not that your body doesn't know what it's doing, but it's what it's getting organized, and it's on the on-ramp. And you don't know yet if you're in the middle zone, the 55-mile-an-hour zone, or the 80-mile-an-hour zone. That's our job to help you figure it out. But yeah, you may have a little bit of stopping and starting, and that's totally normal. When you are in active labor and your cervix is really doing its dilating spontaneously, you generally are going to have contractions every 2 to 3 minutes. And the great thing, I know this sounds weird, but the great thing about labor contractions is, unlike those horrible leg cramps you might get in the middle of the night that come on with absolutely no warning, labor contractions have warning. You can feel them build, you can feel them peak, you can feel them release. And in that 2 to 3 minutes between contractions, they usually last about a minute altogether. But in those, I think people need to flip around in their head, not that they're going from pain to pain to pain, but they're going from rest to rest to rest. Because even at the peak of active labor, you've got at least as long with the rest, if not twice as long with the rest, as you do with the gradual intensity and then release of the contractions. A lot of what having a natural unmedicated birth is also about trust, flexibility, support, the mental effort. I've seen some amazing things happen with partners, with family members. When you've got folks who trust and believe in the process supporting you in that, then, most of the time, there isn't a whole lot more for us to do than just watch that process unfold. Dr. Brickler spent an awful lot of time standing around with his hands behind his back, and that's the model. We gave him an honorary midwife award when he retired. It's that standing around with the hands behind your back, letting the natural process unfold.
I had commented on that with Dr. Oliver. He sat down in front of a mom who was just working on her, initial pushing, just sat down in the stool with his hands folded, just waiting, because she was doing everything she needed to. It was a beautiful sight. So speaking of partners and the support, what do you recommend for women who are planning an unmedicated birth and their support? Do you recommend that they see a doula, that they, get their partner to come to classes with them? What have you seen works best?
I think it depends on the mom. I think she needs to have the person and the team that's the most effective team for her. I think doulas can be fantastic. I think spouses can be absolutely the right person, but occasionally they might not be the right person. Just like occasionally having your mom there might not be the right person. Sometimes she's the best person in the world, but sometimes she's not. And I've certainly been in the situation where we as staff have been helpful with family dynamics, because we don't want you having to feel like you have to do something awkward at a time where that's intense, and you need to be able to go internally working on what's the best thing for you.
Yeah, I would speak to the partners versus doulas and say, particularly with the pandemic early on, I gave birth during a time when doulas were not an additional person you could have. And I know that that's changed now, and that you could have your birthing doula as your support team and your partner or whoever you choose as your one guest. And so we had to do a lot of on-the-fly training, but of course this was not my first baby. So my husband was actually great and did everything more above and beyond than I could have imagined. But it is a difficult process to think through ahead of time and pick who is that person that's going to be there, especially while visitors are limited. So that's definitely one interesting element to birthing in a pandemic, trying to narrow down, okay, who is this person? But it seems to be helpful in getting the right people in the room at the right time. So
it's an opportunity to talk about family stories and family birth stories. I think finding out what your mom's experience was and your sister's experience and your aunt's, and kind of tease that out, because if everybody in your family has had their babies this way and your hope is to have your baby that way, then that doesn't mean this can't happen, but that's going to affect the dynamic in in the labor and the delivery room is, wonderful, critical, and very much a part of what's going on, not just what's going on in the uterus.
Absolutely. Let's see. Trying to jump to a question that makes sense. Let's see. We have talked about preparing for labor, and when we get to the moment of pushing, can you tell us a little bit about that? I think that's the number one question that comes up in my childbirth classes. So Joanna, how do you describe what pushing really feels like?
That transition period between 8 centimeters and being completely dilated, that 10 centimeters where you can start pushing. I do tell all my patients that is the most intense part of your labor. A lot of our moms will state that they start feeling pressure, kind of the same type of pressure, like they need to have a bowel movement. And I like to tell people, if you start feeling that, let us know, because that may mean that that baby's getting close to having a birthday party. So lots of pressure. Crowning is usually the most intense part of the actual baby coming out. People have said in the past that ring of fire, lots of burning, but a lot of times that part is kind of short-lived. So if you can kind of have in your mind that it's going to feel that way, and know that if I power through this, I'm going to have this baby at the end of the rainbow, then I think I think that people tend to know that they can get through that intensity in a short period of time, and that it's going to end. So yeah, it's definitely the toughest part of labor, but it's short-lived, thank goodness.
I also think for a lot of people, pushing is kind of a relief, because there's an urgency to it where you're working with your body. Your body's telling you what to do, and you're not trying to back up and withhold from the intensity of the contractions. It's really kind of a relief to say, okay, let's get into this. I think it's a very positive thing. I think also people need to know that we do have, warm compresses and other stuff that we can use, that grunting or low, deep breathing. There are lots of ways to finesse that baby out of there. And we've got lots of experience making that happen slowly, smoothly, and, to everybody's benefit.
Yeah.
But I think
for a
lot of people, it's a relief.
Yeah. I was going to ask about how to protect the perineum from tearing. That's another major question, but you already hit the nail on the head with that. So compresses, different breathing techniques. I know it was one key item on my birth plan was to say, I would like to be reminded to slow down and breathe. And that was really helpful for me.
I spend an enormous amount of time in labor rooms reassuring people that things are normal, including maybe the burning, including maybe that desperate urge to push, but the reassurance and the calmness of saying, this is a normal process, your body's doing what it's supposed to be doing. Maybe in a few minutes, I'm going to actually tell you, I want you to push hard now, but I may be telling you to slow down in a few minutes. All that stuff, that anticipatory guidance is really, 99% of what we do. People in this country, our culture is so unfortunately toxic to pregnant women. And I just hate that for folks. We really have to normalize the process, and normalize the process even when things may have to switch a little bit. There still are lots of things about this that we can be supportive about.
So once you've pushed baby down and out, who is there to deliver the baby at the hospital? And side note, can you pull the baby out yourself?
Yeah. So, from a nursing standpoint, you're going to have your primary nurse that's going to be there, that's going to be kind of tending to you. And then right at the end, we'll call in another one of our L&D nurses to be what we call the baby nurse. And that nurse will come in and just kind of concentrate on that baby. We are the region's only baby-friendly hospital. So we have a, very big push on exclusive breastfeeding, if that is what the mom's wish is, skin to skin, immediate skin to skin, if that's appropriate. And then that delayed cord clamping, which is evidence-based best practice for those babies. So yes, we do all that. If baby comes out screaming, looking beautiful, we put that baby right up on mama's chest. We let whoever mom wants to cut the cord, if that's something that she chooses, do that. And then we tuck that baby right in there next to mama, and that baby stays there for at least an hour or until the first breastfeeding is completed. The baby never leaves the room, stays right there in the room with you. We don't even have a nursery in labor and delivery. The baby stays right there with mama. And is only taken to the warmer just to get a weight and a quick measurement, and goes right back skin to skin with mom. So yeah, we're really big on that bonding in those first few hours, getting that breastfeeding going if that's something that the mom wants, and just being there for the mom and letting her bond with her new baby.
Nice.
Most people who, sorry.
Go ahead.
Most people who have a first baby with me say it hurt. It was hard work, but it wasn't anything about what I had been so scared about, and it had nothing to do with what I'd seen on TV. I mean, we just have these crazy expectations, and it's not usually like that. If I've had babies that are crying before their body's all the way out, and I say to the mom, reach down and get that baby on your chest. We just do what needs to happen. Now, that doesn't mean that sometimes we don't need to shift gears, but people do great with this, with confidence and support and trust and flexibility and, all the things that very much make a natural unmedicated birth possible. It's absolutely possible. We see it all the time, and it's why we do what we do.
Yeah, you mentioned shifting gears, and it makes me think about the experience of changing your mind. You go in planning a natural delivery, and then you change your mind. When is it too late to get pain medication?
Go ahead, Joanna.
Yeah, I'll go ahead. So the IV pain medication, we do have to kind of be careful with the timing of that, because it's given through the IV, so it goes systemic. So it goes throughout the mom's bloodstream, which then kind of goes to the baby. So once it just depends on how fast you go, but 8-9 centimeters, we start being like, oh, we don't know if this pain medicine would really be the best thing to give you at this point, because that pain medicine then goes to the baby, which can make the baby come out and not really want to breathe as well, because it makes them kind of sleepy, just like it kind of makes the mom a little bit sleepy. And as far as the epidural goes, I think it's important, if you change your mind and you want an epidural, to know that there are certain things that we as the nursing staff have to do to get you prepared for that epidural. We need a accurate CBC, so a blood count for your platelets. Usually that's done on admission, but just know that, if you come in and you're 9 centimeters, 9.5 centimeters, we may not have time to get that lab back. The other thing that you'll need is an IV bolus, because that epidural can kind of lower your blood pressure right as it's starting to kick in. So we give you a fluid bolus that kind of pumps your blood pressure up to keep you from not feeling, because that can make you feel kind of bad whenever your blood pressure drops. And the baby tends to not like that as well. So we kind of counteract that by giving that fluid bolus. So we need to have those two things, labs and your fluids in, before we can get that epidural. I've gotten epidurals for my patients when they're complete. It just kind of depends. We try really hard to do what the mom wants. If the mom wants a natural delivery, we are all for it. We're there as your cheerleader, and we're going to help you through every second. If that mom wants an epidural, even if she's 9-10 centimeters and she wants that epidural, we're going to do everything in our power to make that happen, because this birth needs to be what she wants. So,
yeah.
And I think that we need to throw out the window the notion that they're hard and fast rules.
Right.
I mean, they're really, yes, there are safety parameters, but 4 centimeters, 6 centimeters, 2 centimeters, 10 centimeters, whatever. This is not about hard and fast rules. This is about the whole context of how's mom doing, how's baby doing, you know, what can we do to be supportive and facilitate what's going to work for you?
Yeah. So I've definitely seen, like you said, epidurals at complete or almost complete. And I've also seen, you know, where we've got to get labs in and it's going to be a while. And, you know, so the delay, it's good to know what is needed so that you can be prepared either way. One thing I will add, I talk to my doula clients and to my birthing students that when you want to change the plan, it's a good idea to have communication already set up with your team about what that will look like. Because for some women, being able to complain about the pain and to say, man, an epidural really sounds good, is therapeutic. And they may not actually want an epidural, they just want to complain because it feels good. But there is a time where you want people to take your complaints really seriously, because like you said, it is your birth and you want it to be a positive experience. So I've had a variety of tools for that. Several of my clients have used a code word that works really well. And then for some moms, they want to be encouraged to try other things. Like Miriam, you mentioned earlier where you hit a wall and you change positions. Sometimes that change in positions can really ease the discomfort and make things lovely, or going and getting in the tub, whatever it is. So definitely good to know when you feel very frustrated, how do you want your team to reply? Do you want them to say, great, let's get your fluids going, let's get your epidural, or maybe, you know, hey, let's change positions. So that's one thing I'll add. So let's see. The questions we have from our viewers. Do you recommend questions for epidurals for higher risk pregnancies? Is that something that you recommend to your high risk patients, Miriam?
In some circumstances, I mean, we certainly, I think, are cautious and quicker to go to an epidural. For instance, if someone's had a previous cesarean and we want to be able to, we think we may be going to the OR and there's a greater possibility, so that we are not scrambling in an emergency. Does that mean that has to be the case? No. There are certainly medical situations, and there's some situations where pushing could be an issue, or blood pressure situations that need to be managed with a different plan. One of the great things about my practice is that the midwives, as well as the family practice residents and the docs in the group, are all collaboratively managing those patients. So just because you end up needing an epidural or some additional quote unquote high risk situation doesn't mean that you don't have the support of the entire team. People are not being, just turned over from one spot to another. Again, it's an individual situation, and I think we do a great job of being flexible. What do you think, Joanna?
I agree 100%. I think you have to look at each patient as individual. Don't try to cookie cutter labor, because it's all different and every patient's different. So yeah, I agree with Miriam 100%.
Yeah, this question kind of touches on the blood pressure that you mentioned. How feasible is an unmedicated birth if mom has high blood pressure?
I think it depends on how high the blood pressure is and what else is going on, because there are a number of different situations that involve hypertension in pregnancy, whether it's chronic or pregnancy induced or preeclampsia, whether there's liver and kidney involvement. I don't think you can put it in a box. I do think that, as with all this stuff, if you're coming in from home or you suddenly have a situation where we've got to monitor your blood pressure, we're still going to do our absolute best to listen and facilitate those things that we can do that enable you to have the birth you want. And I know that sounds really kind of ridiculous because I'm being wishy-washy. I'm not trying to be wishy-washy. I'm trying to nail home the point about our determination to be flexible and supportive. I really don't want folks thinking that there's only one way that we do stuff and that's our way. because that is not the case.
Yeah. So it sounds like it's that delicate balance between what's medically safe and needed, and then also taking into account what does mom want, and how to kind of juggle those, which is not a one size fits all scenario. So
it's not. And obviously our ultimate goal is healthy mom, healthy baby, but the process is important too. And having families, not just moms, but families feel that their needs were attended to, their desires were honored, their wishes were met, even when the plan had to change, that they still were in a situation where they were heard. That's critical.
Yeah, I've definitely experienced that with my my own experience. I was not looking forward to being induced, especially because once I got my assessment first coming in, they determined that the only option remaining was for me to have Pitocin, which I had heard so many horror stories about. And I was certain that that would take all of my unmedicated birth plans out the window with it. But it was very doable because they listened at each step. And every time we had to make a decision, my concerns were heard and respected and honored and made it through. So here's another viewer question. Can I have a natural birth after a prior cesarean?
Potentially, yes. Is that fair? What do you think, Joanna?
I think, you know, I can speak to what TMH does. We do Vbacs. But I think you need to discuss it with your provider. Not all providers do Vbac. So I think that should be number one, to make sure if that's something that you're wanting, you're going to one of the providers in town that does do Vbacs. Knowing that with a Vbac, you may have to be monitored a little bit more closely, just because you are at a little bit higher of a risk. So we'll want to monitor you a little bit closer. But that's all something that can be discussed, you know, your wishes, kind of why the team feels like we need to monitor you closer. And so the discussion be had between everyone, we can find a happy medium there. So absolutely.
And I'll add from the doula perspective that I've supported moms at TMH with their Vbacs, and they were able to move and change positions throughout the monitoring. So one common myth is that when you're monitoring, you have to be sitting in one position in bed, and that sometimes can be needed if baby's really hard to track down, but most of the time you can be on a ball or moving. In my case, I was in a tub, to get that monitoring that you need to stay safe during a VBAC, but also the comfort that you need to achieve the natural birthing goals. So
yeah, we may want to monitor you, but we're going to want you to be up and moving, because that helps labor progress.
Yeah, absolutely.
Absolutely. So don't think just because you have, you have to be monitored that you're strapped to the bed. That's not what we want. We want you to be able to move, get up, sway back and forth through those contractions, really get that baby in a good position, so that you can have the birth that you want.
Yeah, absolutely. What advice do you have for moms who have family that are skeptical about having a natural birth? I know with my first, I got lots of comments from a particular aunt about how much I would beg for an epidural. So how do they advocate when they've got this type of criticism?
Can I give you guys kind of a ridiculous answer? I don't know. But when I teach puberty class, one of the things I say in puberty to both boys and girls is that the range of normal in people's bodies is like the range of normal of women's breast sizes. You've got the ping pong balls, you've got the bowling balls, you've got everything in between. We all get that, right? So we also need to get that the range of normal for how people labor is exactly the same issue. We do not just fit in the middle of the curve. And my experience from one labor, one pregnancy to another can be very different. I think that's important for people to know about too. I think a second pregnancy can be really hard for folks. It's challenging in that they think they know what it's about because they've done it before, but they've only done it once. And you don't go into a second pregnancy with the same body you went into the first pregnancy. And so, when we're in triage, when we're in the clinic, when we're in labor and delivery, we see a huge range of what's normal. What's normal is not just what Aunt so-and-so went through.
Exactly. Yeah. So exploring kind of the fact that people tell stories from their own experience might be a good way to kind of reframe the stories you're told. And you mentioned, Miriam, that like movies and TV will tell a very dramatic version of birth. I definitely see that. And there's certain movies that I can't watch anymore because I know the reality and the movie version is not the same. So yeah. Do you guys have any final thoughts for moms preparing and advice to give? I feel like we've covered so much.
It's about empowerment and trust. And that's what we want
Good.
for everybody in your parenting as well. And I also always remind people that pregnancy, like growing up, are not pathologies. And thank goodness we have the excellent, excellent high-risk teams that we have for those occasions when that's needed. But you're having a baby, not a heart attack. Thank goodness we've got heart stuff available down the hall, and we are here at the Women's Pavilion to provide a huge range, an absolutely huge range of ways to be able to have a baby. We can take care of very sick women and very sick babies. We do an excellent job at that. But we also start with the assumption of normalcy, and women are strong, women are capable. We've got great staff. I think we just have to, trust and support the process.
That's beautiful. I can't say it better than that, Miriam. Absolutely. Well, I just want to thank you guys both so much for your advice and your inspiring words. And also thank you to everyone who tuned in for our discussion. I hope you join us for the remainder of our Baby and Family virtual series. This week, our next webinar is tomorrow, Thursday, May 6th at 12 p.m. And I'll be tuning into this one also. It's the pediatric rehab team discussing toys and tools for healthy child development. To see the full lineup and to register for that event, visit teamh.org/fair. Have a great week.
Thanks, guys.